Hello again, friends. This will be an update to a talk on multiple myeloma that I gave over 5 years ago already. And the reason that I want to update this is because, as you know, 5 years when it comes to cancer is really like 50 years. I mean, tons of research is going on cancer, and multiple myeloma is no exception. And I don't like to revamp my talks just because of a few little changes. However, the changes when it comes to multiple myeloma, the changes in recommendations by this point, 5 years later, they've accumulated to such a degree where I do believe that it may affect how the test questions are worded or what they might test on. And multiple myeloma is commonly tested on the USMLE. So this is a judgment call that I've made. I do feel at this point now some of these recommendations have been around long enough to where it may affect the test question. So I do feel my previous lecture is kind of outdated now, so I'm going to do an update here. But do be aware that the updates are not so much to the diagnosis of multiple myeloma as much as it is to the treatment. But we're going to go over both. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right-hand corner of the screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And remember, if you subscribe, you'll have access to some of my premium videos in which I go over case studies, differential diagnosis, treatment plan, things that will be very useful for you for clinical practice and as you get ready to study for Step 3, which, as you probably are aware, has clinical case scenarios which are not multiple choice. And that's very, very, very difficult to some people who are used to the multiple choice format. So having a systematic way to go about cases can be very useful for Step 3. Thank you in advance for your consideration. So in the hematology section, I go over dyscrasias of various blood cells. I'm talking about the leukemias and various cancers with blood cells. When we're talking about multiple myeloma, which blood cell are we talking about? The plasma cell. And the plasma cell can be involved in a couple different dyscrasias, which include multiple myeloma, but also include something called Waldenstrom's macroglobulinemia. And that is, I give a whole talk on Waldenstrom's macroglobulinemia. There are similarities in the pathophysiology and some of the symptoms as well. However, the difference between multiple myeloma and Waldenstrom's macroglobulinemia is primarily the antibody that is secreted in excess. So as we're going to see in multiple myeloma, we secrete excess IgG usually. In Waldenstrom's, it's typically IgM. And there's some differences in the presentation. Although you can have it with multiple myeloma, usually patients with Waldenstrom's are going to have hyperviscosity syndrome, which can cause visual disturbances, dizziness, headache. They also tend to have a higher incidence of cold agglutinins. So it's a little bit different from multiple myeloma, where the symptoms tend to be fatigue, bone pain, renal issues, and so forth. So big difference though between multiple myeloma and Waldenstrom's is multiple myeloma IgG, Waldenstrom's IgM. If you know that, you might be able to get a question right on the USMLE, because sometimes they ask questions as simple and as basic as that. So an overview of multiple myeloma. Remember that multiple myeloma is a clonal proliferation, and it's a clonal proliferation of plasma cells. And most commonly, as mentioned, they are IgG secreting. And for that reason, we commonly give multiple myeloma and syndromes like it the term gammopathy, gamma being the G segment of IgG. So it is part of a spectrum of disorders, which include monoclonal gammopathy of undetermined significance, or MGUS, smoldering myeloma, and multiple myeloma. And this is kind of a crescendo, as we're going to see. The diagnostic criteria of multiple myeloma includes those for smoldering myeloma and for MGUS. By definition, multiple myeloma is always symptomatic. always symptomatic. You can't have multiple myeloma without having symptoms. There are approximately 20,000 cases that occur in the U.S. per year. And the median age of onset is in the later 7th decade of life, so 68 to 70 years. The ratio of blacks to whites is 2 to 1. However, I do believe where I got that, that 2 to 1 is actually in the proportion of blacks versus the proportion of whites is 2 to 1, not actually the total number of blacks to whites. The chief symptoms include bone pain. That's the one you got to remember because 70% of patients with will present with bone pain. They can get pathologic fractures. Remember that pathologic fractures are just fractures that occur from insignificant trauma. So you fall out of bed. Do you expect to break your femur when you fall out of bed? Absolutely not. So if you fall from 20 feet on the roof, then yeah, you expect to break your femur. But if you fall out of bed and you break a bone, that's not something we would expect. So that's a pathologic fracture. It's a fracture that occurs from just incidental trauma. Neuropathy can occur often. That's because of entrapment of nerves that run along bones. So one of the places I think of is entrapment of spinal nerves. The vertebrae are a common place for you to have these lytic lesions, and when the bone compresses because of decreased integrity, it can compress a spinal nerve, and that can cause a neuropathy. But these neuropathies can occur really anywhere. Pallor and fatigue due to decreased red blood cells, and that is that can be due to a little bit of crowding in the bone marrow, but also due to an anemia from chronic disease. Weakness along the same lines, increased infection. Why increased infection? Well, if you've got all these plasma cells crowding out other plasma cells, what are plasma cells supposed to do? They're supposed to create antibody. Antibodies fight infections. If your bone marrow is going schizophrenic and it's creating antibodies that are useless and not creating antibodies that you need, well, then you're going to have increased infections. And those infections are going to be the types of infections that we expect are warded off by antibodies. And then ecchymoses, probably along the same lines as the others, you're not creating as much platelets. So unlike most hematologic malignancies, the diagnosis for multiple myeloma is clinical. So you do need a bone marrow biopsy as a necessary component of the diagnosis, but this just really stresses the fact that you need to have symptoms. So most hematologic malignancies, you can only make the diagnosis on biopsy. In multiple myeloma, you need to have clinical symptoms. You have to have symptoms in order to have multiple myeloma. So what are those symptoms? Well, 70% of patients with multiple myeloma will present with bone pain or bony tenderness. So that they might just actually say, doc, my back hurts right here, or my shoulder hurts right here. Or, they may have just general pain or malaise, and you press their chest or you press their leg and ow, that hurts. So bone pain or bony tenderness, 70% will have that. Other common presentations include the pathologic fracture, which I suppose would be painful, spinal cord compression, fatigue, malaise, and neuropathy, as we kind of already went into. A minority of patients will present with symptoms of amyloidosis, which is due to light chain deposition, and signs of amyloidosis include swelling of the shoulder joints, subcutaneous nodules, and macroglossia. And I talk about amyloidosis in another talk. Okay, here's a big pearl for the USMLE and for practice. So that is this mnemonic CRAB. And CRAB is useful because it's sort of your end organ symptoms of multiple myeloma. Now, some of these aren't really symptoms, they're manifestations, but these are the manifestations that are consistent with multiple myeloma and that will contribute to making that clinical diagnosis. So this is the mnemonic CRAB, C-R-A-B. The C stands for hypercalcemia. Yeah, I know hypercalcemia doesn't start with a C, but it's got C in it, so it's going to suffice. Hypercalcemia. So what is hypercalcemia? Well, it's an elevated Calcium level. Well, what are the symptoms associated with hypercalcemia? Remember, that's stones, bones, abdominal moans, and psychiatric overtones. So I'll talk about that in the endocrinology section. Hypercalcemia. And why do we get hypercalcemia? It's because of increased bone turnover. So remember that these disordered cells in multiple myeloma, they secrete something called osteoclast activating factor. Not only does that decrease the integrity of the bone, cause these lytic lesions, but it also increases the plasma calcium level, and that's going to cause additional symptoms. Renal failure. So look for an increased BUN and creatinine. Anemia and bone pain. So anemia, you're going to have, obviously your typical pallor, fatigue, etc. And then bone pain, pretty obvious what that means. So the diagnosis. Although the most accurate and obviously most critical test is going to be a bone marrow biopsy, you need to have that to make your diagnosis. Several other tests should be performed first. So plain films should be done in any area where there's bone pain, tenderness, or possible fracture. Although in many cases, when you have a patient with suspected multiple myelomas, you're going to get just a general skeletal survey. You should start off by getting films of any area where the patient reports tenderness or where there's a possible fracture. You want to get routine labs. So a CBC alongside a smear. The smear, we're going to talk about why you want to get a smear. CMP, so like a BMP, calcium, liver function test, all that's going to be really important. You're looking at your renal function. You want to look at that all-important calcium. And then an ESR can be useful, and a urinalysis. Now, when we suspect multiple myeloma, you don't want to just get any urinalysis. It's ideal to get a 24-hour urine collection. So if you get a urinalysis, make sure and ask the technician to look for Bence-Jones protein, as we're going to talk about. But ideally, we'd like to get a 24-hour urine collection, a little bit more sensitive for some of the things that we're looking for in multiple myeloma. And then these two other things called a UPEP and an SPEP. And these are chiefly performed when you're looking at plasma cell disorders, multiple myeloma, Waldenstrom's. So very important that you know what those are. So what do we expect to see? Well, in routine labs, your CBC will typically show a normocytic anemia. We have slightly decreased red blood cell production and also kind of an anemia of chronic disease going on. So normocytic anemia, your MCV should be between 80 and 100. The CMP will often show hypercalcemia. And if you were to get a PTH, as you should anytime you have a disturbed calcium level, that PTH is going to be low. This is not hyperparathyroidism. This is increased calcium from increased bone turnover. So the PTH should actually be low. You should also see uremia. If you do a BUN creatinine ratio, as you should always do when you have a disturbed renal function test, that BUN creatinine ratio should be below 20:1, and that's because this is not renal issues due to dehydration. This is actually intrinsic renal issues. If you get a peripheral smear, as you should, should see red blood cells attached in a line. And what is that? That's called a rouleau. And a rouleau, as we're going to see, is a line of red blood cells. And that occurs, these rouleaus, what they are, it's really a non-specific sign, but you always will see rouleaus when you have increased plasma protein. So this can occur from other things. It can be from infections, it can be from multiple myeloma, but it can also be from Waldenstrom's, and it can also be seen in connective tissue disorders. So it's really non-specific, but on the USMLE, the most common place you're going to see rouleaus is going to be in multiple myeloma. A skeletal survey should show these lytic bone lesions if you get it in areas where there's pain, but also if you do a skeletal survey, you may see lytic bone lesions incidentally. These lytic bone lesions often described as like a soap bubble appearance, and I'll show you a picture of what that looks like, or may be described as like a salt and pepper appearance if they're smaller. 24-hour urine collection will generally show proteinuria. In specific, Bence-Jones protein. The protein should be greater than 1 gram per 24 hours. If you get a SED rate, it should be elevated. That's really non-specific. I avoid SED rates like the plague. Some physicians, though, swear by them. So, if you want to get one, get one. If you don't, I wouldn't fault you. Serum protein electrophoresis. So all this is doing is it's taking the serum and looking for what proteins are in it, and it's organizing them by size, and we expect a certain pattern in the electrophoresis. However, when you have multiple myeloma, remember that you have this increase in IgG. And that will be reflected in the electrophoresis. You'll have a spike because you have a ton of IgG. And IgG will show up on one particular part of that electrophoresis. So you have this big peak that we wouldn't normally expect to see. And that is called the called the M spike, and that's from the IgG. And we can also call this the M protein. And that's a clonal expansion of IgG that's coming from these disordered cells that are in bulk, schizophrenically creating antibody. And this helps you differentiate from Waldenstrom's macroglobulinemia, although for the test you should know that Waldenstrom's macroglobulinemia tends to present with more with this hyperviscosity syndrome, but Waldenstrom's macroglobulinemia tends to be IgM, whereas multiple myeloma is IgG. Urine protein electrophoresis can be really useful for identifying that Bence-Jones protein. I think it's really only a minority of just urinalysis or 24-hour urine collection will actually demonstrate the Bence-Jones protein in specific. So the urine protein electrophoresis can be really useful for nailing down that Bence-Jones protein. So if you're getting SPEP, you might as well get UPEP. UPEP will help you find Bence-Jones protein. And then once you get all this and you still suspect multiple myeloma, at that point, you're warranted to go ahead with a bone marrow biopsy. And on bone marrow biopsy, in order to differentiate multiple myeloma from some of these other things, you need to have more than 10% plasma cells in your bone marrow biopsy. Okay, so this is the rouleau. I think you have to have more than 10 in a chain. So to have like 3 is not unusual. But you have to have more than 10 connected in a chain. And so you see these little lines of red blood cells. And this is ultimately what would lead in, because this happens to a much greater degree, but in Waldenstrom's you get massive collections of these rouleaus, and ultimately this clogs up the little arterioles, and it's what causes that hyperviscosity syndrome. But you do see this to some degree in multiple myeloma. Here's the lytic lesions. You can see the soap bubble appearance in the skull. Here you see it in the forearm and the ulna and radius. So it can be all over. It decreases the integrity of the bone, and as you can imagine, it can lead to nerve entrapment. One of the big things that it can lead to that's very common in general, but you see with increased incidence in multiple myeloma, is carpal tunnel syndrome, and that's because that little nerve goes through the carpal tunnel, and any little disturbance to that is going to cause a collapse of the carpal tunnel, and it's going to lead to carpal tunnel syndrome. So here you can see more lytic lesions here in the hip. This is a pathologic fracture. These are not common areas to get a fracture, so if you see them, you really should suspect something pathologic. But really, in order to diagnose a pathologic fracture, you have to go by history. Obviously, if you're in a car wreck and you have fractures like this, well, it's probably not pathologic. But it also helps that you see some of these lytic lesions going on here. You wouldn't expect to see that in a fracture in this area if it weren't pathologic. So the diagnostic criteria for multiple myeloma, you need to have all 3 of these criteria. So the first off, we already talked about your CRAB symptoms, which are end organ symptoms or labs characteristic of multiple myeloma: hypercalcemia, renal failure, anemia, and bone lesions. You also, so those are the symptoms. You don't need to have all 4 of those, but you need to have at least one of these end organ symptoms. You also need to have monoclonal protein spike on SPEP or UPEP, and typically they'll be both. And then you also need to have greater than 10% plasma cells on bone marrow biopsy. So you have to get the bone marrow biopsy. That's not really a choice. And by the way, I believe when I talked on Waldenstrom's, I gave a picture of what an SPEP would look like when you get the reading back. So if you really want to visualize what SPEP is, go back and look at that talk. I believe I do talk about the SPEP in greater detail. So the diagnostic criteria, what's MGUS, what's smoldering myeloma, what's multiple myeloma? You need to know the difference because USMLE will probably test it. So multiple myeloma, remember, you have to have the M spike on SPEP, you have to have the Crab signs, and you have to have the plasma cells, more than 10% plasma cells on bone marrow biopsy. Well, a smoldering myeloma is multiple myeloma just without symptoms. So you have the M spike and you have more than 10% plasma cells on bone marrow biopsy. So it's really asymptomatic multiple myeloma. Okay? MGUS is just the M spike. So typically what happens, you might be asking, well, how would you diagnose MGUS if it doesn't have any symptoms? And the way that you would diagnose this is, let's say just routinely you're getting a serum protein on a patient, and that serum protein comes back high, and you think, well, why? So maybe that prompts you to get an SPEP and a UPEP. You're going to work this patient up for multiple myeloma. Even though they don't have symptoms, you might want to work them up just in case, down the road they develop symptoms. Well, that SPEP will come back with the M spike. And so at that point, you have an M spike, you don't have Crab signs, and let's say you were to do a bone marrow biopsy on this patient. You would come back with a normal biopsy, less than 10% plasma cells. And so that would be MGUS. All you have is the M spike, nothing else. And that's why it's called monoclonal gammopathy of undetermined significance. All you have is the monoclonal gammopathy. So MGUS, really, we don't do anything for. We just watch and wait. And approximately 1 to 2% of these patients per year will go on to develop multiple myeloma. So it is a useful diagnosis because these patients are at significantly increased risk of developing multiple myeloma, but in and of itself, MGUS warrants no treatment, just watch and wait. So usually this will go on to smoldering myeloma, and smoldering myeloma, at this point now, you have an abnormal bone marrow biopsy. Now, we're not going to be doing bone marrow biopsies on these patients every 6 months or every year. We'll wait to get a bone marrow biopsy again until they develop Crab signs. But this is just indicating that there is a middleman between MGUS and multiple myeloma. So at some point, these patients with the MGUS, they will start to develop more plasma cells in their bone marrow, and that number will go on to exceed 10%. So these patients, again, we continue to watch and wait, but these patients have a higher rate of progression into multiple myeloma. Now, you may consider referring these patients to a study group, but that's not going to be asked in the USMLE. So again, watch and wait. And most of these patients, or many of these patients, will go on to develop multiple myeloma, and the only difference between smoldering myeloma and multiple myeloma is, you guessed it, Crab signs. So they have to have symptoms, or they have to have a high calcium level. And so at this point, multiple myeloma, the treatment is chemotherapy and or autologous bone marrow transplant. Typically with autologous bone marrow transplant, we're going to do an induction chemotherapy first. And in not all patients can we do a bone marrow transplant. There's criteria for that. So let's get into the treatment. So the treatment for multiple myeloma, far and away, the most effective therapy is going to be an autologous bone marrow transplant. Okay, we're taking the patient's own cells and transfusing them back into the patient. Now, the patients need to be assessed for whether or not they're a candidate for bone marrow transplant. Typically, patients who are over the age of 65 or patients who have serious comorbidities are not candidates. The reason for that is that the induction therapy, the bone marrow transplant itself, is going to cause more problematic effects than if we were to just treat them for their multiple myeloma, just with long-term chemotherapy. So we tend to reserve bone marrow therapy to young, healthy patients, and by young I mean under 65. But if you look at recommendations, you're going to find disagreement. So typically 65 is the middle of those recommendations, but some people more conservatively might say below 60. Some people more aggressively may say below 70. So if you have a patient on USMLE who's a candidate, look for 45 years old and healthy. If you have a patient who's not a candidate, look for 73 and very ill. So let's say that they are bone marrow transplant eligible. Well, the first thing we're going to do is primary induction therapy, and this is where there are disagreements. So if you don't remember all three of these, it's okay because there are a lot of different induction therapies. One of the things, though, that you may want to remember is this new drug called bortezomib. And bortezomib is, like I said, it's a newer drug, but it's a proteasome inhibitor. And it just came along, probably within the last decade. But it's as it's becoming more and more studied, it's beginning to supplant some of these other regimens. And so, there were older regimens that were used and may still be used, but bortezomib is really supplanted a lot of these. So bortezomib, cyclophosphamide, and dexamethasone. This, I would say, would probably be the right answer if it came up on the test. However, I don't expect the USMLE to test you on this because there are so many different kinds of induction therapies. If you're taking the ABIM, maybe they might ask this, but USMLE probably will not ask this. What the USMLE will want you to know is whether or not the patient is a bone marrow transplant candidate. So you've done primary induction, now you do the bone marrow transplant, and then after that you will do maintenance therapy with lenalidomide, and this is a new recommendation that's come out very recently. So induction, transplant, and then maintenance therapy with lenalidomide. I don't expect that to come up because, as we're going to see, this recommendation just came out very recently. So if the patient is not eligible for bone marrow transplant, then we do long-term chemotherapy. And this really has not changed. And because this is very time-tested, this is fair game for USMLE. So long-term therapy is with melphalan, steroids, and thalidomide. So melphalan, prednisone, thalidomide. There may be some differences as far as what exact steroid you use, but for the most part, it's melphalan, prednisone, and thalidomide. So this is for patients who are treating basically symptomatically with chemotherapy for multiple myeloma. These are ineligible people for bone marrow transplant. So you treat symptomatic hypercalcemia with hydration and loop diuretics. We're going to get into that, but this I really want to stress. If the patient has symptomatic hypercalcemia, remember stones, bones, abdominal moans, and psychiatric overtones, you will treat them with hydration and loop diuretics, including furosemide. Second line would be bisphosphonates. We try to avoid that because it's so easy to cause the patient to go symptomatically hypocalcemic with bisphosphonates. So we try to treat them taking advantage of their own physiology by using hydration and loop diuretics, but if that doesn't work, you can go ahead and use bisphosphonates. I would never do that without a nephrologist personally, but that would be your second line. As you can see, 6 months ago, March 2018, it was just published that lenalidomide is the very first drug approved by the FDA. I guess this happened a little more than a year and a half ago. The FDA approved lenalidomide for maintenance therapy in patients with autologous stem cell transplant, bone marrow transplant, who are being treated for multiple myeloma. So lenalidomide is your maintenance therapy after transplant. I don't expect that to come up on the test because this is really only, a year old. But, if you're watching my video in 2022, then maybe this will come up on the test. Hopefully, not hopefully. I hate having to go through and find out that my videos are outdated. That's never very fun. So there you have that. So management of complications, renal failure, obviously hydration, because the cause of the renal failure is due to immunoglobulins clogging up your nephrons. Hydration is useful to help flush those out. Hypercalcemia, we talked about hydration, diuresis, and you can also add glucocorticoids. Second line is bisphosphonate. Bone pain, destruction, fractures, bisphosphonates are useful, helps strengthen up those bones, draw calcium back into the bones. Local radiation can be used as well. Infections, we didn't really go into that too much, but remember infections can happen because of decreased proper. So you're supposed to be making antibodies, right? But with multiple myeloma, you're making antibodies, but you're making tons of useless antibodies. So you get infections because you're not making proper antibodies. So there's really nothing we can do. We can't we can, but there's really no way practically to give these patients regularly give them antibodies. So they're kind of in a rough spot as far as infections. So the best thing you can do is prophylactic vaccination early on and try to stimulate antibody production before an infection actually happens. For anemia, remember this anemia is caused from a lot of different things. It's a little bit of anemia of chronic disease, a little bit of bone marrow issues, and then also because they can get renal failure, it can also be because of kidney disease. Remember, chronic kidney disease, you can get a decreased red blood cell because of decreased erythropoietin. So you can supplement them with erythropoietin. Some final notes, you may see as a lab beta-2 microglobulin. It's a very useful surrogate marker to measure their tumor burden. And so it's also useful for prognosis, can be used to monitor their response to chemotherapy. Renal function is also a pretty useful marker for their prognosis as well. As of 2018, I kind of talked about this too. The therapy for multiple myeloma, as well as MGUS and smoldering myeloma, which there really isn't therapy for that, but part of the progression, really remains complex. There are tons of different regimens that would be correct. If you're a hemato-oncologist, I'm sure you've found this lecture very unsatisfactory. But this is just for general practitioners. So what I gave you is the bare bones of what you would need to know, but really it's a very complex field. So we only just touched the surface of it. Very, very complex, lots of research, multiple drugs can be used, and many have been recently approved. For USMLE Step 2 and Step 3, it's important to know how to diagnose these disorders, how to differentiate multiple myeloma from MGUS and smoldering myeloma, and also that autologous bone marrow transplant is the most effective therapy for symptomatic multiple myeloma. And remember, by definition, multiple myeloma is always symptomatic. And that's all I have for you. If you have any questions, write me a note below. Otherwise, I will see you next time.